Good morning. My name's James Stanger. This is a webinar for InPress articles on 17th of July, 2025. Okay, so my name is James Stanger. I've got a PhD and I've been an embryologist for more than 50 years. These videos for my YouTube Fertile channel is an attempt to bridge the gap between information that you may need for your fertility treatment and the most recent publications available to your clinic staff. I'm not a medical person and this information is not medical advice, but may help you in asking questions about your treatment with your doctor. I hope it helps. So, what has been published on the 17th of July that I think is worthwhile? There are three publications as always. One is a rare case of a live birth for a 46-year-old woman. The second, it looks at the epigenetic changes and how that relates to your chance of pregnancy. And the third one, which I thought was really worrying, was the risk of mortality in family members of men seeking fertility treatment. So briefly, the first publication I want to discuss is from Australian authors, and it's an open access article so anyone can read it, and the web link is down here. So this is a report highlighting an exceptional case of a woman aged 46 who achieved a live birth through IVF using her own eggs. Now, the reason the author published this case was both to demonstrate the possibility of it and to recognise that there is a real concern about the awareness amongst women of the profound effect of age on fertility, and that this awareness remains very insignificant. So it talks of a case of a woman who at 46 had several cycles of treatment, but she had one more cycle at 46 and she fell pregnant and had a live birth, and the child is healthy and the mother's healthy, so everything's fine. However, the author was concerned that this one case did illustrate the concern that people often don't know about the risks of the chance of pregnancy on women over 45, and that educating women about these age-related reproductive challenges is crucial. And that couples in their early years may benefit from freezing their oocytes so they can maybe try to achieve a pregnancy at 46. But if you are coming through at an advanced stage, egg donation still stands as the most pragmatic alternative. There was a period in IVF back in the early 90s when oocyte donation was being used to achieve pregnancies in older women, and there were quite a few clinics trying to achieve pregnancies in women aged over 50, and I think there was a couple of pregnancies in women aged 60. However, after 1 or 2 years, this practice has largely been stopped and is no longer recommended, primarily because even though a woman can use eggs from a young lady and have quite a high chance of pregnancy, that is, the uterus is still receptive to healthy, viable oocytes. If the uterus has been primed correctly with drugs, the concern is that women in their 50s and 60s are physically just not able to handle a pregnancy, but more importantly is that they're more likely to be dead before the child reaches maturity. And the business of the health of the woman achieving a pregnancy in older women is rarely discussed, but as a gynecologist, I'm sure they are concerned about it. And it should be a question that you should ask your doctor if you are in the mid-40s, whether I am fit enough to be pregnant. However, the possibility of the author suggesting is of a live birth amongst women at the extremes of reproductive age using their own oocytes is very low, and he puts it at 3 in 1,000. Therefore, it's important to approach this case with caution to avoid unrealistic expectations amongst women aged 45 or over seeking IVF using their own eggs. The second paper is a funny way of talking about similar things of maternal age. But in this case, they're looking at epigenetic age and fertility treatment and asking the question whether the epigenetic clock could forecast success. So in the field of IVF, the search for reliable success indicators or predictors continues to be ongoing, with novel biomarkers gaining increasing attention. Epigenetic clocks, that is, mathematical models based on DNA methylation patterns, have revolutionised ageing research by providing insight into biological ageing. And I'm sure many people are aware you can have your biological age tested, and sometimes you might be younger than your biological age, and other times your epigenetic age might be more than your biological age. So in this study, they looked at 380 women, of which 204 achieved a live birth. Generally, they were younger, had better ovarian reserve markers, achieved more eggs, but importantly, had a lower epigenetic age. So they were younger. Their epigenetic age was 3 or 4 years younger than the women that did not fall pregnant. However, after adjusting for how many eggs they collect, the antral follicle count, the epigenetic age remained significantly associated with a live birth. That is, very high probability. Suggesting that IVF success is more likely in epigenetically younger women, irrespective of their ovarian reserve. And so they're hoping that if your epigenetic age is tested, it may give you some idea whether you are likely to have success or not if you're in your mid-30s. Now, the last paper I'd like to talk about is one from the USA. It's a closed article, so you can only read the abstract, which is shown. But for some time, there has been talk that the male reproductive age, their semen analysis, is an indicator of male health, that men with low sperm counts often have higher health risks. And this paper is interesting to see whether family members of such men also have significant morbidity or mortality. And so if someone, even though it's been shown that poor semen analysis may be linked to coronary or diabetic or other aspects of poor health, it's unclear whether this extends to family members of a man with low sperm count. That is there a genetic component? They looked at 666,000 odd men. The relatives of men who came for treatment, there were 183 men, and the rest were relatives. They included the analysis, but they concluded that relative to the men with a normal sperm count, the all-cause mortality risk increased significantly for men in the families of men who are oligospermic. Oligospermia means low numbers of sperm. Close relatives, first and second degree relatives, mortality risk, including death due to cardiovascular disease, congenital birth conditions, etc., all increased. This is kind of a sweeping statement, and I think it's a shame this article wasn't open access because people need to read it. And they concluded that their results suggest that a familiar all-cause and cause-specific mortality risks differ by fertility phenotype. That is, families of azoospermic men, that men with no sperm, and oligospermic men, that men with few sperm, showed significantly increased risk, particularly of close relatives. This study provides further evidence that shared genetic or environmental factors could influence both fertility and somatic health. So, from this point of view, if you are attending fertility clinic and you have a sperm test done and the result comes back really disappointing, very poor numbers of sperm, then that should be an indicator to you that your health risks have increased, and also not only for you but your family members, and that maybe you need to bring those into discussion, and it's certainly something you need to discuss with your clinician. So I hope this information may help you. Please tell other clients about the service, and if you like, please subscribe. Thank you very much.